Hi everyone, this is Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. I have another very interesting case for you guys. So this is of a patient who attended with either a benign osteonecrosis in the left ear or an external auditory canal cholesteatoma. I feel it is a benign osteonecrosis, and I'll explain why during the course of the video. So this is their left ear. You may have seen their right ear, that was clear. So in this left ear, they've got this occluding wax near the entrance. It's slightly matted. It's got a sticky consistency to it. And I'm going to use microsuction, the new Rycorette, and also Forceps. And in the end, it was the Forceps that helped remove this. And just where the suction probe is ear, underneath there, there's some granulation tissue there. So granulation tissue is inflammatory tissue, and essentially it's tissue that's formed during the healing process. So here we kind of can tell already there's been some sort of trauma to the ear as a result of the granulation tissue, and it is connective tissue that has its own vascular supply, its own blood supply. Deciding to use the correct, kind of leverage this out, but what it's actually done is spread this soft wax across the base of the ear canal like soft butter. So I'm just going to the posterior canal wall, I'm gliding it in. So with the design of the Rycorette, it's got a tapered tip, so we can kind of get in between, should I say, the wax and canal wall. You can see it's quite matted here. So what is benign osteonecrosis and canal cholesteatoma? They quite often can get misdiagnosed with one another, but essentially both conditions can lead to a localized erosion of the floor of the ear canal in the case of a benign osteonecrosis. With a canal cholesteatoma, you can get erosion of the temporal bone. The temporal bone is the bone that encompasses the bony part of the ear canal, the inner 2/3, and it's considered to be the second strongest bone in the body behind the femur. The two mechanisms behind the development of the erosion of the ear canal is somewhat different. With benign osteonecrosis, it's considered to be due to poor vascular supply, so to poor blood supply to the temporal bone, which then means the bone doesn't receive all the oxygen, the nutrients and minerals that it requires to sustain life. And that leads to necrosis of the bone, so decaying of the bone, and eventually separation of the bone, and we call that sequestrum. And when the bone is, that process, the old process is actually umbrellaed under the term bony resorption. And under bony resorption, that bone that has kind of decayed away, all the minerals are transported to other parts of the body via the bloodstream, and those minerals are deposited elsewhere to form new bone. So there's kind of a recycling process. So when you have a crater created because of the loss of bone, then the skin that lines the ear canal can dip, and you get a huge widening. And this patient's got a massive crater. You'll see it in a moment. It's absolutely humongous. And you've got all this dead skin invading this crater. Another way to look at it, you've got a pothole on the road. There's a big indentation on the road itself. So this patient's got an indentation to the ear canal. So benign osteonecrosis, the underlying mechanism is poor blood supply, leading to the death of the bone. And the bone then kind of decays and it separates, creating a crater. A canal cholesteatoma is somewhat different, the mechanism different. That's due to a dead skin cyst. We call it a dead skin, but that skin actually almost acts like a tumour to itself growing. So the outermost layer of this skin cyst, tumour, if you like, is still alive and it's reproducing itself, but it can also contains a lot of dead skin. And this skin cyst, cholesteatomas are more typically found in the middle ear due to a retraction of the eardrum, and the dead skin from the ear canal as it's migrating, it gets trapped and that forms into a cyst, and that cyst gets bigger and then it invades the middle ear and up towards the brain, so it can be lethal. It can lead to death if untreated. So with a canal cholesteatoma, they're far rarer, and the skin cyst develops into the ear canal, and the skin, as it decays and dies, it releases lysosomal proteolytic enzymes, which then basically causes necrosis and ulceration of the skin. So the skin is chewed up, and underneath the skin of the ear canal, you have a thin layer called a periosteum. And that sheath, this thin layer, sits on the bone of the ear canal, and the periosteum supplies the bone with all the blood, the minerals, the nutrients that it requires to sustain life. So you can think about it a bottom-up and a top-down mechanism. So I would call a benign osteonecrosis a bottom-up cause. So it's the underlying bone that dies first, which then creates the crater. And whereas a canal cholesteatoma is more of a top-down mechanism, it's the dead skin cyst that releases enzymes and that chews up the flesh, leading to an ulceration of the skin. That can then cause periosteitis, so an infection, inflammation of the periosteum. And because the periosteum is no longer able to supply the blood to the bone then decays. With a benign necrosis, as I said, it is exclusively localized to the floor of the ear canal. With a canal cholesteatoma, it can be most common on the floor of the ear canal, but you can also get it on the anterior canal wall, so the front part of the ear canal and the back part of the ear canal. But almost always with a canal cholesteatoma, you will get discharge, there'll be otorrhea. And this patient didn't have that today. Although they got granulation tissue, there's no active discharge there. And in addition, with a canal cholesteatoma, depending on the stage of the canal cholesteatoma, but you're very likely to get ulceration of the skin. Here, there wasn't no ulceration of the skin. The skin was intact, and you'll see that. So this patient had this huge crater, and lining the crater was dead skin. In the case of canal cholesteatoma, normally you'd expect an ulceration of the skin and the underlying bone exposed. Now, that can also happen with a benign osteonecrosis, but in this case, it wasn't so. So you can see some more granulation tissue there. So with benign osteonecrosis, it's more prevalent in the elderly population, most probably because they have reduced vascular supply. Patients who may have undergone local radiotherapy around the ear, because that can cause damage to the vascular supply. It's also believed to be more prevalent in the male populations. And patients who take bisphosphonates, I hope I pronounced that correctly, they can sometimes be medication taken for patients who suffer from osteoporosis or Paget syndrome. So that's with the Paget syndrome, that's when the bones can become quite large, but then also weakened. And osteoporosis, of course, is when the bones become weak and become more brittle. So the thing that I don't fully understand, and I was trying to read up a bit more about it, bisphosphonates are designed to help with weakened bone formation. So I'm not sure how that then can lead to osteonecrosis, because people take that medication as a mechanism to prevent weakened bone. I'll probably do a bit more reading on that, but that is one of the potential causes of benign osteonecrosis, according to the NICE guidelines, which are clinical guidelines in the UK. With benign osteonecrosis, it doesn't have to be bilateral, it can be unilateral. In fact, it's most commonly unilateral, which again is a bit surprising, because if it's due to poor vascular supply, you'll think that would affect both ears equally, but apparently it is more prevalent unilaterally, so in one ear. Patients who suffer from benign osteonecrosis do suffer from really severe psoriasis, so itchiness of the ear. With benign osteonecrosis, you don't always get an occluded ear like this. With a canal cholesteatoma, typically you do, or a keratosis obturans. So this is not a keratosis obturans, because the keratosis obturans, the widening of the ear canal, it's more diffuse, it's more global, it's all around the perimeter of the ear canal. So we know that this is not a canal cholesteatoma, purely because the erosion is on the floor of the ear canal. With keratosis obturans, you can get granulation tissue like this on a grade 3, and the skin is normally intact with a keratosis obturans. So you've got to be careful not to misdiagnose this, because it can be quite easy to do so. But because this widening is at the floor of the ear canal, it's localized, it's not diffuse, it's not global, we know it's not a canal cholesteatoma. We can be pretty sure that it's not necrotizing otitis externa, so that's a very rare condition, and patients who do suffer from necrotizing otitis externa, typically, not always, but patients who are elderly or immunocompromised or diabetic, and that can cause osteomyelitis, which is an infection of the whole bone around the ear and the skull, and that can be fatal, that disease. And common symptoms with necrotizing otitis externa is you have a lot of moist granulation tissue at the floor of the ear canal, and also nocturnal otalgia, so pain at night. And the theory behind that pain at night, because when your bone is infected, I think it's the gate theory of pain. When you're horizontal and at night, your body secretes less endorphins and cortisol, which are both anti-inflammatories, and you develop increased inflammation due to cytokine storms at night. So patients who suffer from bone conditions typically experience more pain at night than in the morning, just because there's less natural anti-inflammatories secreted at night due to circadian rhythms. Our bodies have kind of daily rhythms, even hourly rhythms. I forgot what they're called, but I know circadian rhythms are daily routines that your body undergoes. So we know it's not that. We can be pretty sure of that because the patient doesn't report any otalgia. There's no mass granulation tissues, no moist granulation tissues, no active discharge there, which is another common symptom of both a canal cholesteatoma and a necrotizing otitis externa. So these conditions are keratosis obturans, benign osteonecrosis, canal cholesteatoma, and necrotizing otitis externa. It's going to be able to diagnose between them. And what I'm trying to do here, I just want to see that there's no exposed bone here, and there's not. So I'm not going to peel this away. It's too thick a layer of skin. This is going to need continuous debridement, and you're going to need this crater cleaned out on a regular basis, because you know this is just going to collect with dead skin and wax moving forwards. This can become quite serious. It can start eroding towards the jaw joint. So we have made a referral to ENT by the patient's GP. And another potential cause is misuse of cotton buds. So if you use cotton buds or poking in the ear and you graze the ear canal and you damage the periosteum, so that sheath that supplies blood and oxygen and nutrients to the bone. So even using a simple cotton bud or poking your ear can restrict the vascular supply to the ear. So guys, stay away from the cotton buds. So treatments, as I said, is regular cleaning of the ear. There can be surgery to relocate or some more periosteum. So basically you're increasing the vascular supply to the bone. But they also the ENT trying to fill in that area, so to put fatty grafts or muscle grafts there to patch up that area. Another known treatment is hyperbaric oxygen therapy. So it's when you put you in a chamber, and it just helps to provide a lot of oxygen to this area, because that's the underlying cause. So to increase blood flow. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.